The first session we're going to do today, we're looking at lockdown radiology, and we're going to look at the intracranial hemorrhages. So 6 cases that we're looking at. We're going to be looking at a short bit of history and then questions for consideration. So the first case was a case of head trauma, hit by falling object. The question we were asking is, what's on the scan and what will you comment on? Do I have a willing volunteer to take the first case?
Sure, Derek. I'll take it.
That going to be yourself, Mason, right? Let's see if this works. So remote control. So Hassan, right. You should be able to hit a button and then you should be able to get control of the mouse.
All right. Tap here to control Derek's screen.
Nice. There you go. So you'll be able to scroll with the middle button on your mouse if you got it, or press up and down on the keyboard.
I'm just using my iPad.
Oh, that works, yeah.
All right, I see. It's quite nice. So CT head, non-contrast. The most obvious abnormality is sort of high density in the overlying the left parietal bone, in a sort of lentiform shape, and there is compression of the lateral ventricle as well, the left lateral ventricle, with some midline shift as well.
Okay.
I would measure it. I would draw a straight line down here and try and measure it. Yeah. The high attenuation is likely to be blood. So this is a acute subdural hematoma.
Cool. So I agree with your description, Hassan. You're good with that. So I'm happy with that. So we've got, what I'm going to do, I'm just going to take this back. So I'm going to got control there. So yeah, so we've got this hyperdense lenticular biconvex egg-like collection on this side. It's underlying the parietal bone. It's also underlying the frontal bone here. So if we cheat and have a look at the bone windows, you can have the reconstructs there. That's the suture there. And so this bleed underneath is crossing the suture. So we've got under the frontal bone, under the parietal bone, mass effect as he described, bang on. So this sort of shape, this is going to be an extradural hemorrhage. Okay?
Oh, extradural, sorry. Yeah, I always get it mixed up.
It's fine, so it's why we're doing this, okay? So you've got this bleed here and you're bang on the description. So it's something which is this kind of bulging shape. I keep it simple as well. It looks like an egg, okay? If you can buy that kind of description, so it's an egg stradural, seems to work for me. And the mass effect is the right thing that you're talking about. We've got the midline shift over here, and as we start to come down, we'll see more cases of this as we go along. You've actually got that temporal horn's too big for this degree. They haven't got that much cortical loss, they haven't got that much brain loss, so that temporal horn's a bit big. It's also asymmetric to the left-hand side, and you should be able to see the ambient cisterns here. And when we get some MPRs up, we'll see, so this is already some uncal herniation at this point, so there's other signs of mass effect going on. Posterior fossa is all right, and you can see the other associated injuries. So we've got soft tissue swelling over the orbit where they've been whacked, and this swelling here. So the thing was, what's the other thing that we would be looking for? What's going to be associated with this bleed?
The left injury to the left middle meningeal artery.
Yeah. So that's going to be the common site for these extradural bleeds. Yep. And why? How does the MMA get injured?
A blow to the pterion plate.
Yeah. So we're looking for the fracture. So you always look at bone windows, and you're right. This is the pterion here. So this is the thinnest part of the skull, but we're designed stupidly. It's also the easiest place to get a punch to. And right underneath here, you're right, we've got the middle meningeal artery. So this is a common site to look for fractures, especially if you've got people with extradural hemorrhages. So always have a look at the bone windows. And think about the clinical history you'll be provided. It's usually going to be a high energy trauma, and there can be, we talk about a lucid period happening. Bear in mind, the dura sits right up against the periosteum. It's part of the skull. So to get blood filling in this space, it's got to be a hell of a pressure to tear. You're actually tearing the bone apart by getting the blood in this space. So that's why there's a headache, but it's also part of the thought why there's a bit of a lucid period before that starts to expand. Sure. So it's something to think about. So we've got some other cases here. So again, thanks, Hassan. It was a good shout. So we've got a crash in a traffic accident. So again, it's a young adult. It's a high energy insult. And this is just a more exaggerated version of it. Hyperdense, egg-like, lots of mass effects. All this, we should, even brains our age, we should still have a bit more CSF up at the top here. So it's always useful to come to the vertex and have a look. You can see we've got sulcal effacement already up at this level. We've got the big extradural. And as you come down, you start to see these are the ventricles pushed right across on this side. You've got lots of other clues that this patient's not going to be doing well, because this is just to show as well, we've got another view. Look at all your other views. Look at your coronals to show the midline shift. And they're also tubed, and they've also got the fracture in this same area that we'd be looking at. So this fracture is ripped through the bone, ripped through the suture, and has come down in the pterion there. And you can see underneath that, that's where that blood is just filling this extradural space. Again, 6-year-old head trauma, and this is a really gross example. Again, we've got less brain, so there has been a bit of volume loss, but we can see that there's sulcal effacement right up the top here. And we've got this parieto-occipital hemorrhage here. You can see if it was a subdural, it would be creeping around the edge here. Instead, this is pushing the brain out. And as you come down, you can see it bleeding into the posterior fossa as well. So that's a concerning sign that it's crossed the compartments. If you have a look here, you've got this central blob in the middle, and it's a weird place to get a bit of a parenchymal bleed. You can get contusions associated with these extradurals, but if you have a look, you can trace this back, and it's actually blood inside the temporal horn of the left lateral ventricle. So there's so much midline shift, your temporal horn is now crossed midline already. So that's not a good outcome. If we look on this patient as well, what's the other concerning thing anyone can shout out here? What's something I would want to be seen in the conclusion of this report?
It's gas.
Yeah, so we've got gas inside the head. So what does that mean the clinical team have to be doing?
So like a basal skull fracture, so infection.
Yeah, and as we come up the top here, we see there's all this gas here. There's bound to be some crack in here that we can't see. But you follow this down, you can see there we've got this temporal bone fracture. So there's going to be gas from the mastoid air cells coming up into the skull. But even if they've got, with that, or if they've got a fracture in the skull vault as well, they're going to need to be giving ceftriaxone. So you need to be, that's an unexpected, it's a kind of a complication of these extradurals. You want to let them know that there's an open fracture and they need to be giving antibiotics early. So with the temporal bone fractures, you can spend ages picking apart which bit of the temporal bone's involved, but no one's going to read your report. They'll just say complex temporal bone fracture. Things to comment on is the otic capsule. So you see around the internal acoustic meatus and around your semicircular canals, you've got this really dense bone here. If you get fractures which extend through here and crack into this, then there's going to be sensory neural disturbance. So that's something that's worth commenting on, saying the otic capsule is preserved or is violated. And it's the same thing as well with the middle ear bones, with the ossicles. You can just say if there's obvious disruption, if they're ripped apart, that's a bad sign. But you can sort of caveat it. It depends if you've got good bone recons on your CT heads, which at the Royal we do at St. John's. You can sometimes ask for them to be reformatted. Cool. Right. So next case, 91-year-old fall from standing. We're thinking about risk factors and what can help with imaging. We've got Dr. Nania is on neuroradiologist joining in.
We can see there's brain volume loss in this gentleman, which we kind of expect. There's associated ventricular dilatation, but we can see here that there's something quite hyperdense of the at the falx is best seen on the coronal view. Don't know how to get that.
I'll tell you what, I'll give you the coronal view there.
Yeah, so this was the money shot for me.
Okay, so I agree with you that it is hyperdense there. What about looking around the rest of the brain now that you've seen something there?
So you'd want to see if there's extension either way, but I wasn't convinced I could see an extension into kind of the tentorium or the rest of the lobes.
Okay.
It's bilateral volume loss. Sometimes you can get isodense subdurals, but yeah, don't know if I'm missing something.
No, it's fine. Okay, did anyone else see anything else?
Was there something in the ventricles?
So we've got this really hyperdense stuff. It's very calcified in both sides here.
It's just choroid plexus, isn't it?
Yeah. So this is choroid plexus, and this is what a lot of people will kind of focus on and get interested in, but it's something which is sometimes our job to say that it's normal. And I like that you were looking at in the falx. So this is a nice place. Parafalcine subdurals, we think about bleeds here, quite often get overlooked, but this is actually really quite dense, probably closer to bone than to what I'd expect blood to look like. So this is just a bit of falcine calcification. So you were right to be starting to think about looking around the outside. And when we get to this level, you start to see there's things that we want to be seeing. We want to see brain coming all the way up to the skull. Even with volume loss, your sulci should be, your gyri, should be coming up to meet the skull. And when we look over here, we start to see there's something starting to get in the way. Now it's hiding because it's just deep to the bone and it's really shallow. This is where I encourage people just look on getting some sort of blood window set up, or just click and drag to the right and up a bit. And you start to see that there's actually blood sitting in this subdural space here. So this is a really thin subdural hemorrhage. And again, on the coronals, you were kind of just drifting over it, Vicky. I thought you were about to fall on it. But as you come forward, you start to see that there's just blood filling in here. Now, it's not a lot, but this guy's warfarinized. So that's kind of important information you want to get in the clinical history. This is where we care about people being on anticoagulants and scanning them within time. So my advice for subdurals, especially kind of older patients, this is what we're going to be expecting to see. You've got brain atrophy, you've got more tension in these bridging veins through the durals, through the meninges. And when you have a low energy trauma, you can get tearing of these bridging veins. I've just got to have a look at these spaces and have a look in coronals, really useful for subdurals. So this is another similar case. So this one I reported on call. So again, this is one which you could walk past, but as you see, we've got some volume loss on this side and we've got this stuff stopping the brain getting up to the skull. And when you put it on coronal, so cheat mode 1 and cheat mode 2, putting on the blood windowing, you see we've got this rind of blood coming all the way around inside the cerebral convexity. And this is another place where blood tends to hide, is sitting over the tentorium. So you can see that it's thickened and hyperdense compared to the left-hand side. When we go back to the axial, you can see there that they've got this blood starting to fill in the middle cranial fossa. So if you think about this is now kind of, if you have your brain in a sous vide or in a little bag, it's just kind of going to be surrounding the brain in there. So that's where the subdurals will sit. I reported a scan a couple of weeks later in the Vic, and he was again another one who was anticoagulated, and this bleed had progressed. And this again shows the extension. It's that same kind of distribution. There's just more blood. He's had a repeat bleed on this. This is acute on chronic with this blood in this area. You get that impression there where it's filling in again and starting to have a bit of mass effect and pushing across. Again, decreased level of consciousness, minor head strike, so low energy trauma, but this is concerning neurology. And we've got this subdural here. Why does it look different, guys? Anyone want to say?
There's old and new blood.
Yeah, so we've got an acute on chronic bleed here. So this is the bit that Albie was starting to talk about with aging of blood. So what happens is as you get, when it's acute, it's this hyperdense. And then as it starts to age, you get protein breakdown within the blood. You get the blood constituents will then start to settle and separate out. But what happens is this is just the old blood and clot which is broken down. This is the new blood, and you get this hematocrit level. You'll see this anywhere in the body. Remember, straight lines are bad. So this is an appearance of an acute on chronic with quite a bit of mass effect for this patient. And a few weeks later, so after about 3 weeks, it starts to become hypodense to brain. And this is appearance of a chronic subdural hemorrhage. Vicky, you were mentioning about stuff being kind of close to kind of old fluid and old hematomas. Sometimes you can get collections which are the same density as CSF. So they can either be very old resolved hematomas, or they can be hygromas from other reasons. If you're needing to really pick apart a hygroma or a hematoma, it's going to be something which has happened ages ago anyway, isn't an acute finding. MR can help, but it's not going to be an emergency thing. So don't worry about calling it a hygroma or an old hematoma on call. It's the acute stuff you want to be worrying about. Now, let's see. No one's had a look at this one yet. Laura, following on you. You there?
Yeah, hi.
Yeah, cool. So let's give you that. Have a look at this head. Tell us what you think's going on. So again, patient's confused, bit of a headache. It's one of those non-specific ones that doesn't get done overnight. We hang it on, it can get done in the morning.
So the first thing is at the base of the skull, there's a lot of artifact. So there's not a lot of sulcal space for someone with an old brain. So
yeah. So I agree with your assessment there. So we've got a bit of artifact down here, but you're right up at the top here, we should be seeing more CSF, shouldn't we?
Mm.
So because we didn't do this one immediately overnight, they've had a bit more time, and they've come back and they've said that this patient actually had a sort of minor head trauma. They fell and hit their head about 2 weeks ago.
Mm-hmm. So they hit the head 2 weeks ago?
Yeah, 2 weeks ago. And they've been a bit confused since then.
Would I don't know, the only thing I know that causes like widespread injury would be like a diffuse axonal injury, but I thought you would get sort of more loss of grey-white matter differentiation with that.
Yeah, we can see the grey-white differentiation pretty well here, can't we?
Yeah.
And remember our chat, we were saying that the gyri have to come right out to the skull edge. So actually we can see that's stopping there. The guys gave contrast for this case as well, and we can see these are the little peel vessels. So this is the brain here, and this is something crescentic on both sides. So what do you think this is?
So this is just a massive subdural.
Yeah, so this is a bilateral subdural, and this is a sneaky case, okay? And what has happened is after, as we said, the density will change over time. So after about 2 weeks, it can be isodense to cortex. So this is all subdural blood on this side. This is all subdural blood on this side. This patient's got bilateral sort of subacute subdural hemorrhages. So it's a nice pickup. So it's a good place just to look. If you can't see brain coming all the way out to the edge and there's something in the way, have a think about subdurals. So third case, we've got a young woman, headache and vomiting. So the questions were how to describe this bleed and what test would we do next. Pauline.
Yes.
Getting to have a go for this one.
Okay.
So young patient, headache and vomiting. We'll start at the top and work the way down.
Yep.
So we've got CSF.
Mm-hmm.
Mm-hmm.
So the abnormalities at the right temporal lobe.
Yeah.
Can you scroll up and down a little bit?
Yeah, so that's up.
So that looks like it looks parenchymal.
Yeah.
So, but in a young patient without a history of trauma, it'd be quite unusual. Usually parenchymal hemorrhage is from like hypertension people that already have like a history of hypertension and things like that.
Mm-hmm.
Given the history, I don't know if it could be like an extension of a subarachnoid, just purely because of the history, really. But
yeah, so headache and vomiting, you see what I mean? Yeah, so you would do the blood windowing, have a look, see if there is anything in subarachnoid space. This is just a parenchymal bleed. So what do you think the next thing that we can do as radiology to help might be? You said that you're a young patient. What should we be doing with young patients under 50?
Angiograms.
Yeah, so we can do angiograms. And you can start to see if there's other kind of weird abnormalities. So if you've got a big lobar hemorrhage, but you've got hyperdense vessels around it, things like that, you can see vessels coursing through it. You want to think, is there an AVM? Is there something else going on here which has caused this? Now, this is a tip which Jeremy mentioned just a couple of weeks ago, is you can see there's a wee bit of edema around this. And that's a clue that this is a parenchymal bleed. So it's not something which has come from outside in, pushing on the brain. But if you've got a bleed inside the brain, you can get a bit of reactive edema around it. So what structures are right beside this?
So the transverse sinus.
Yeah, they went on and did a venogram for this patient, where you get a bit of an arterial phase as well. But as you come down here, concentrating here, you see we've got a filling defect in this patient's transverse sinus. And there's the bleed. You can see the bleed. There's the bleed in the sagittal view and the coronal view there. And as you look at the transverse sinus, you see here we've got this filling defect in this, and this is a big blocky thing. It's not an arachnoid granulation. So we've got clot in the venous sinus. And what happens is when we think about strokes causing infarcts and then hemorrhagic petechial transformation of them, it's because we've stopped the supply to the brain, so the brain dies. But what happens with venous sinus thromboses is instead of turning off the tap, we put a plug in the drain. The blood can't come out of the head. So it backs up, and what you get is these capillary hemorrhages. So this is a venous infarct, a hemorrhagic venous infarct, because what has happened is we've stopped off the drainage and it's backed up and caused a bleed in a weird place inside the head. What was that?
Sorry, that's someone on the bus, sorry. I'll just, I might just mute myself.
Go for it, yeah. The other thing to have a look at is always have a look, if you've got a clot somewhere, check all the other veins. Because if you look over here, there's no contrast on this side. So they've got clot on that side. And you look right up the superior sagittal sinus, this patient's got clot up here as well. So this is a young 45-year-old patient with extensive venous sinus thrombosis. And they've got a bleed as well. So what we normally do with patients who have got deep sort of sinus venous thromboses, what's the treatment?
Anticoagulation.
So these patients should get anticoagulated, and when they've got a bleed, that's obviously going to confuse things, but that's something which the stroke team and the neuro guys have to take a lead on. But we have to pick up the bleed, have to pick up the venous sinus thrombosis. This was the same patient. So it's something that we have to bear in mind, but it's not our decision to make as radiologists. But if you get a patient who's deteriorated, scan them again, because this is what's happened to this patient. Big extension of their hemorrhage and lots of that edema around it. Case 4. Okay, so we've got fall, loss of consciousness, reduced GCS. Who do you need to call and what complications do you see? So who have we got? Dylan, since you're leaning in.
Yeah, cool. I can take that.
There you go.
So starting at the top, you can see there is extensive extra-axial collections over the left cerebral hemisphere with mixed attenuation, some linear low density within that. And there is midline shift to the right side and a complete effacement of the left cerebral hemisphere and also the left lateral ventricle. So going, it scrolled quite fast. So at this axial slice, I can also see there is some blood product in the left tentorium cerebelli, and the extension of the extraaxial collection extending down to the left temporal fossa. Looking at, on the axial slices, looking at the basal system specifically, now I can see that is the starting of the cord, but at this slice, looking at the foramen magnum, there's crowding of the foramen magnum on this slice, but I can still see some CSF surrounding the medulla.
Yep. Good. So what do you think this bleed up top is?
So given the extension of the bleed, I think it's subdural.
Yeah, and you can follow the shape of it as well. It's just caused a lot of mass effect. So why is it that different density? Why is it heterogeneous?
So it could be the different age of the blood products within the collection.
Yeah. So you remember the acute and chronic that we showed before? It's kind of got that bit more of a layering kind of established thing, and then the acute bleed.
Yeah. The other thing I'm thinking about, whether could that be marrow fat within that collections or other debris within the collection?
So it's a good idea to think about bleeds elsewhere. There's not usually enough marrow fat around the skull to do that. But what's happened in this case, this is just a hyperacute bleed. So sometimes you just get this swirling, active bleeding, clot forming in bits and then being broken up in other bits, or if their patients are on anticoagulants as well. So if you scan patients, sometimes within the first hour, after their injury, not after they come into A&E, we sometimes get this weird sort of marbled appearance to the hemorrhages. So that was good. So what I just wanted so you did a nice review, huge mass effect over here. We've got all of the sulcal effacement on this side, as well as all of this brain being pushed in. And as you come down, you're right that this is just a bit busy down here. That's not brain at the front there, so that's blood as well. So we've got blood into the prepontine cistern here. But what's a really concerning thing, I don't know if any of you spotted this, but we've got this little blush here, okay? So we've got blood in the middle cranial fossa. This is the same density, so this is hemorrhage in here. It's not in the ventricles. Yeah, thank you for the arrow. Okay, so it's not a ventricular bleed, because when we put it onto the coronal view, we can see it's in here. So I'm just going to bring the chat window in again, because there were some messages while we were doing that.
It's because of coning. It's a durate or dure hemorrhage.
Yeah, good. So it's a durate hemorrhage. So what happens is, because we've got so much mass effect, it was nice pick up, Tom, because we've got so much mass effect, not only is the brain being pushed across from under the falx from left to right, you get an uncal herniation from all the brain coming up top through the tentorium. So you can just talk about transtentorial herniation. We're not quite at coning stage yet. We've still got foramen magnum CSF, but what's happening is you've got all this brain being pushed down on top of the brainstem. And what's happening is you're getting just little vessels exploding within the brainstem. So this is a brainstem hemorrhage from compression up top. So it's called a durate hemorrhage. Nice work, Dylan. So we've got case 5, dizziness, collapse and headache. So the question is, what is this? What's caused it and how can we prove it? So this patient with collapse and headache and reduced GCS. So what can you see there, Nathmi?
So there's increased attenuation right frontotemporal areas that looks like fresh blood.
Yep.
There's also like increased brightness in kind of the tentorial areas.
Yeah, so the tense up here, but you're kind of talking back around here, yeah?
Yeah.
Yeah.
Just around the pons there. So I wonder if this is a subarachnoid with kind of...
Yeah, good. So we've got all this blood and it's sitting in the basal cisterns. This should be black. This should be the same color as the ventricles, yeah? So this is subarachnoid blood, and this is just spreading through the basal cisterns. And there's a good pickup, as you said. So you kind of get the starfish appearance, where you've just got the basal cisterns filling with blood. And as you're right, you've got all this blood sitting up around here and spreading up through the sylvan fissure. So when you come right up to the top of the brain, things look okay down there. We don't have any sort of peripheral, or you sometimes get traumatic subarachnoid blood hiding in the sulci right up the top. But we start to see we've got a bit of swelling here because we've still got CSF in this side. We've got blood filling in the CSF spaces here, filling in the Sylvan fissure, big blob there, and then all this blood swilling around this patient's basal cisterns. And you can keep tracking it down into the posterior fossa. You can see it surrounding the brainstem all the way down here. So, question is, what has caused this subarachnoid hemorrhage?
So I think the number one cause is kind of a berry aneurysm rupture type thing.
Yeah, cool. So how are you gonna? What are you gonna do next to find out?
Not sure.
Dr. Nania, do you want to step in?
You do a CT angiogram in every case of subarachnoid hemorrhage, unless it's a clear traumatic source and a clear traumatic distribution. But even then, you can think about it just to be on the safe side. If you look at the distribution of bloods, you probably can make a guess on where most likely is the aneurysm here. Is MCA bifurcation, I guess.
Okay.
Yeah. So that's good. So this patient, guess what, didn't have their angiogram, which is annoying. But if you think about it, you've got your internal carotid coming up here, internal carotid on the other side. Your ACA starts there and comes up here. ACA comes up here. You've got your A coming here. I'm having too much fun with this. And up the back, we're going to ignore this. That's your basilar. Reverts down here. PCA, change the color, and you've got your PCOM, which connects this bit and this bit. So if we think about places where aneurysms are going to form, they're going to form at areas where you've got pressure coming against each other. So the common places that we see are ACOM aneurysms and the PCOM aneurysms. Because on this side, you've got all the blood from the right carotid impacting against all the blood coming from the left carotid. So any weakness in that wall is going to exacerbate over time, and that aneurysm is going to grow. And similarly at the back here, if you've got PCOM aneurysms, it's because you've got the carotid pressures hitting the basilar pressures. So these are places to look at for where you're going to have to look for aneurysms. The other bit that can happen is when you've got vessels which are branching. So your MCAs branch out here. So anytime that blood's going to run into a brick wall, what happens is you can get aneurysms forming there. So this patient's going to have an MCA bifurcation or trifurcation aneurysm here. And that's interventional neuroradiology, Albie, isn't it? It's done.
Done and dusted.
Done and dusted.
Is PCOM more common than ACOM?
No, they're more or less the same incidence. But basically, yes, so there is always some degree of flow dynamics changes that are implicated in the origin of aneurysm. So
you might get some added things saying the patient also has a blown left pupil. So then you might say it might be a left PCOM aneurysm pressing against the oculomotor nerve. This again is another case. Again, this is not as gross as the last one, but we've got blood filling in the sulci on this left-hand side around the falx. And as you come down to the basal cisterns, you've got this filling in. So it's hyperdense around the basal cisterns. You're also starting to see hydrocephalus as well. So these temporal horns are bigger than we'd expect to see. The ventricles don't look awful up here, but they're slightly rounded, and you've lost all your CSF space around the outside. So even for a young patient, this patient's already showing signs of hydrocephalus. There's no big obvious blob at either side for an ICA, and this patient did have their angio. And you can see there, this is this gourd-like ACOM aneurysm hanging off. You've got your pericallosal arteries here, so this is the anterior communicating artery aneurysm here. And this is another case which is a subtle pickup, where if you have a look, there's just a bit of density in between the cerebral hemispheres. There's a bit of muck down here coming into the interpeduncular cistern. You need to rely on the history here. This patient did have a headache. They did an angiogram. You can see on the sagittal as well, you can just see that there's some blood filling in this sulci. So there's not a heavy blood burden on this. But when you do the angio, they've got this big, juicy ACOM aneurysm, ACA aneurysm, which they've gone on.
That's what happens with delayed rupture a lot of the time, that the blood is not that dense anymore and it kind of disappears. Sometimes patients don't present straight away. It's just the lingering of symptoms that makes them go to hospital.
So if you're sitting on call wondering, should I do this now? The answer is probably yes. It's going to be easier to do. And if you see something on the table, just get them. If they're saying that they think it's a subarach, make sure that the patient comes round cannulated, because you're going to end up wanting to do an angiogram. And just to show, this is what it looks like in the lab. So this is coming up the left internal carotid, MCA, and the branches over here. And this is this ACOM aneurysm filling in here. They fiddled and did some stuff and put some more wire in. That's probably about 7 hotel trips of metal that they put in this person's head. But at the end of it, they've still got preserved flow coming up both anterior cerebral arteries. So they managed to preserve flow through that anterior communicating artery after treating the aneurysm. So our last case, and so this is an older patient, collapsed, confused, and vomiting. And we're saying, what do we need to comment on, and what do we think the cause is?
So we have a left-sided mainly parietal, occipital, parenchymal hemorrhage.
Yep.
But it's quite strange, like it's quite heterogeneous. And there's interventricular extension of the blood as well.
Yeah.
At left lateral ventricle. And there's a small subdural on that side as well.
Yeah, so there's quite a lot going on in this case. We've got this big blob of blood, but this, if we think about where the blood is, it's mostly in the brain parenchyma. So you just kind of have to say, listen, there's more of it here. It's going to be a primary parenchymal bleed. And you're right, they do have, you've spotted the kind of this very thin subdural over here and the interventricular extension. So there's a few things in this bleed which is kind of weird and it's worth commenting on. So you were saying earlier that it's kind of heterogeneous. If you think about it, these are the bits of bleed and this is the edema around it. So remember, parenchymal bleeds are going to have this edema. If you had a bleed from the outside coming in, you might not have so much edema. But people kind of buy that these are finger-like extensions. It looks like there's been a bleed that's kind of exploded and spread out. So if you think bleeding here and it's kind of spread through the brain with these finger-like extensions. So we've got bleed in an elderly patient, finger-like extensions. They've got intraventricular and extension out into the surface blood, which is why we've got this subdural. Does anyone want to shout out what they think the underlying pathology might be for the patient?
Amyloid?
Yeah. Yeah. So if we think about lobar hemorrhages, we kind of think about hypertensive bleeds, which we'll see in a minute, general grotty small vessel change of the brain, so arteriosclerosis. We have to think about amyloid and cerebral amyloid angiopathy. The reason being that if we can say and give the information to the stroke team from the initial scan, there's not just a big old bleed. You've got this extensive change in subarachnoid surface blood, it's just that added extra you can put in. And this slice as well, you can see that we've got pooling of blood in the occipital horn on the other side as well. So that this kind of counts as part of the subarachnoid extension. But regardless, any lobar hemorrhage, what we should be doing is we should be measuring the biggest dimension, be it AP or transverse, and then just give them all 3 dimensions. Tell them as well if there's interventricular extension and tell them if there's hydrocephalus. If you go into the protocols folder in our shared drive, there's a bit down the bottom about how to describe parenchymal bleeds and lobar hemorrhages in there, because there are certain tick boxes which, if we can give them the information, they won't call you about again in the middle of the night shift. And this is
for a case like that, you would probably want to do anyway an MR as a follow-up to make sure that there is no underlying mass, and you'll probably see a lot of other small bleeds that you can't appreciate on CT in keeping with amyloid.
Yeah, so amyloid patients may also have signs of previous bleeds, siderosis, and things like that, which you'll see in a susceptibility sequence. This is another one as well, and this is quite typical. Patient may be hypertensive, but the majority of this bleed's focused down around the basal ganglia, and you can just see it's a big blob of blood. It doesn't have these extensions. It's just sitting there. Sure, it extends up into the lobe. We can call them hypertensive bleeds. There's a bit of an argument about is hypertension a cause, is it an effect, or does it have nothing to do with it? Just call it a basal ganglia bleed with extension into the lobe. And again, you would say if there's any interventricular blood, maybe a wee bit there, measure it, and then say there's no hydrocephalus, or if there is, and then let the stroke guys take it from there. These patients don't need neurosurgery involvement unless they're actively coning, worsening hydrocephalus, or neurologically knocked off. So this is information that you should give to A&E and discuss with stroke, and they can be the ones to call neurosurgery. So we're trying to move away from saying, there's a big bleed, call the neurosurgeons. Nice big juicy trauma. So your head's not meant to look like that. The guy's taken this skull as an Easter egg, cracked into there. It's got all the things that we don't want to see. We've got gas on the inside. We've got a little bit of surface blood there. You could probably stick your finger in that gap up there. Loads of intraventricular blood. That's just a little bit of CSF that's left around there. This is kind of the traumatic subarachnoid blood that we were talking about. So when you've got this blood just filling in the sulci, that patient doesn't need an angiogram. If you just saw this, they don't need an angiogram with a history of trauma. That'd just be a traumatic subarach. And you can see we've lost grey-white differentiation all the way around in this cerebral hemisphere. And another sign as you come down, we talk about the white cerebellum sign. So you can see that you've got everything else is dark around here. This is all edematous, is dying in front of your eyes. But you can sometimes see that the supply in the vasculature to the cerebellum can be preserved until the end. We've covered quite a lot just in this hour. So we've looked at extradurals, think about associated fractures and things you would comment on. Think about subdural bloods, remember your windowing, and remember that blood can age as it goes on CT. Talked a bit about transcompartmental herniation, subfalcine, transtentorial, coning, and then also the effects on the brainstem. Venous thrombosis and complications, subarachnoids and the diagnostic tests that we as radiologists can do to help along the way, and think about the different types of parenchymal bleeds.